I'm Jim Mold, and this is the first in a series of recorded interviews with individuals from around the world who have embraced the goal-oriented approach to healthcare. The country of Belgium, and Flanders in particular, have been leaders in the adoption and implementation of goal-oriented care. So it's particularly appropriate for me to meet first with Jan De Maeseneer from Ghent in Belgium, who was an early adopter and a leader in the development of the concept in Belgium and around the world. Thank you, Jan, for meeting with me today.
It is a pleasure and privilege, Jim, to talk with you about this goal-oriented care.
When did you first become aware of it, and why did it capture your attention?
It was in 1991 that I read the article that you wrote on goal-oriented medical care in family medicine. And I immediately said, yes, this is it. At that moment, I was a starting professor that had to teach the discipline of family medicine in undergraduate medical training program at the Faculty of Medicine and Health Sciences at Ghent University. And in goal-oriented care, I saw a way of operationalizing the patient-centered concept that we were very familiar with. And for me also, this concept of goal-oriented care reminded me of the May 1968 movement, where we were talking about emancipation of the person, the patients that have their own voice in the health system. And I said, well, goal-oriented care, that has to do with this emancipatory movement, with people that express themselves, that formulate what really matters to them. So for me, it was really something I took immediately. I put the article in my course, and the students have had to read it, and we discussed it with the students. And so very early, this was integrated at Ghent University in the curriculum.
I forgot to fully introduce you. You are a professor emeritus of family medicine and public health and primary care at the University of Ghent. You're also the head of the World Health Organization Collaborative Center on Family Medicine and Primary Health Care. So how has the concept affected your work? Where did you go from those first years of implementation within the curriculum? What's happened since then?
Well, what we did also, we emphasized this in the practice. I've been working in a community health center in what then was a deprived neighborhood in the city of Ghent, where we looked after patients coming from almost 100 different countries. And so it was very important to bring this concept of what really matters to the patient in our daily work. But of course, we wanted also the students to look for that. So in our communication training of our students, undergraduate, we emphasized that it was important to look for the life course of the patient, to change the question from what's the matter with the patient to what matters to the patient. And that was importantly integrated in the communication training. And when it comes to the practice, of course, we had clerkships, but very often students did not see goal-oriented care put in practice. They saw other traditional models of doctors that knew everything and that prescribed what patients should do. So in the analysis of their work, students had to reflect on this concept of goal-oriented care and how that could make a difference. So that was the way we integrated in the teaching. And then in 2010, there was an opportunity because we had a discussion on chronic care in the Belgian context. Belgium in 2010 was at the presidency of the European Union. And so we had some topics to bring in. And we had a study afternoon focusing on chronic care. And there I had the possibility to present goal-oriented care as a kind of paradigm shift from the traditional vertical disease-oriented approach that we were at that moment putting into practice, diabetes program, renal failure program, COPD program, and so on. And I have there taken the point that you have always developed. You have to start from the life course of the patient. And then, of course, his morbidity conditions will be looked after from that perspective. And so I could bring that there at policy level. And that was important because in 2012, our National Institute for Knowledge in Medicine wrote an important report, policy report on chronic care. And there the concept of goal-oriented care was really written down very clearly. And the reference was made to your work, Jim. And I think that was an important moment, but because that was the starting point of what is still ongoing today in Belgian policy, that is that we try to implement as much as possible goal-oriented care in the integrated care approach of our country. And we do that not only at the federal level, also at the regional level. In the Flemish region, there has been implementation of this concept of goal-oriented care. And already in Flanders, the past 2-3 years, thousands of young providers and in primary care, social workers, family doctors, nurses, occupational therapists, psychologists have been trained in goal-oriented care. So capacity building is ongoing, and there is a lot of stimulus to make that happen. Also, our Primary Care Academy is putting emphasis and stimulating research on goal-oriented care. And Professor Pauline Boekstaans that made her PhD in the first decade of this century on goal-oriented care. And she has become in Flanders the lead of that movement to develop in research and in training the dimensions of goal-oriented care.
And I hope I'll have a chance to interview her as well. Do you think that I have my own opinion about this, but do you think that there is something different about Belgium that made it more palatable, more acceptable? I know that your efforts at the policy level were critically important, but it's hard for me to imagine that happening in this country at this point. What's different about Belgium?
Well, I think that we had a strong movement of young family doctors that were influenced by the May 68 student movement, and that said, we want to create another type of practice, and we want to change the interaction between doctors and patients, because that's not okay. So we have to change that. And so there was a kind of will to change the practice of medicine. Of course, we had a very traditional health system, so that was not immediately appreciated. But what we did was also we emphasized the importance of interprofessional cooperation. And in the 80s, we started with community health centers, where doctors, nurses, dentists, psychologists, physiotherapists work together on the chronic care for the patient. And in that movement, we very quickly, early in the 80s, we made a kind of request to our government to create an integrated needs-adjusted capitation system. And that is a system where your community health center receives an integrated sum for the different disciplines to provide care to patients. And that stimulated us to look much more and to start from the patients and from the patient's agenda and to have this kind of patient-centered approach. And of course, in Belgium, we had a long tradition of personal relationships between providers and the patients. And that was also very important because we could build on the expertise we had in that relationship. And that's, I think, one of the reasons that Belgium took this up. And of course, in the recent years, the Belgian governments have put a lot of effort in strengthening the primary care. We organized at the Flemish level now primary care in primary care zones where people take care of 100,000 more or less citizens and organize the primary care according to the needs of those communities, organized and supported by the regional government. So that was an important change point also. The other thing is that personally, I had a lot of international context. I was asked to give the James Mackenzie lecture in 2011 for the Royal College of General Practitioners. And there I took the topic of multimorbidity, goal-oriented care and equity. And that was published in the Journal of the Royal College of General Practitioners. And that gave in Europe a lot of publicity, if I may say, to this concept of goal-oriented care. And later on, when the Wonka has published the book on the 100 most important articles for family medicine. I had the honor and the privilege to present your article as a contribution to that book. And of course, that has contributed also a lot to the debate internationally about goal-oriented care.
Now, I know that you mentioned some of the disciplines that are involved in your community health centers. One of the ones you mentioned is physical therapy. It's not common in the United States to have physical therapists as part of the primary care team, or occupational therapists, rehabilitation therapists. Uh, in rehabilitation, I think the idea for me grew out of my experience in geriatrics and rehabilitation. And the rehabilitation specialists already use a goal-oriented approach, at least some of them. Do you think that was helpful to your efforts, the fact that other disciplines besides doctors were already doing this?
Yes, absolutely. And the thing that we learned from physiotherapy and from occupational therapy was the importance of the international classification of functioning. And of course, very often, goals of people are related to functioning, to be able to visit grandchildren, to be able to participate in local activities. That is very important, and that has to do with functionality. And so I was very happy when in the WONCA and in the WIC with the International Classification of Primary Care, the third version, that we integrated functioning in the classification system, because that is what we learned from the physiotherapists. Functioning is a key aspect, and a lot of activities we do in primary care are related to improvement of the functioning of the patients. Another thing is, of course, that we also saw that goal-oriented care is important. For instance, when you have family problems, where children have difficulties at school, also there this approach of formulating goals at the individual and at the family level is very helpful. And we did a lot of work also in that sense to make clear that we as primary care providers have to go together with the patient to walk the talk and to go for improvement of the relationships within families, for the achievements of the goals in terms of quality of life and well-being that they have formulated for themselves.
I'm glad you mentioned children. I've had when I've tried to promote the idea in the United States, people think that it only applies to old people or people with multiple chronic conditions.
That is not true. I think there are many situations where this concept of goal-oriented care is important. And that is why now, actually in Belgium, I'm involved in the creation of the Belgian Integrated Health Record. And we created a new kind of what we call an authentic resource, and that is the life goals of the patient. The idea is, and we are going to look we can put it into practice, that patients can write or make a drawing or use icons to describe what really matters for them, what makes their lives worth to be lived. And one of my dreams is that we start every consultation with that screen. Because if we would start with that screen, the conversation between the provider and the patient will be focused on the patient's needs and the patient's goals, and not on the recent laboratory results that have arrived or the new medical imaging that has arrived about this patient. And one of my dreams is if we could start it that way, it will help us to start from what really matters to the patient. Actually, I'm working on the realization of this integrated health record. The idea is that we will work together with different providers on the same platform, and so that we can, within the different episodes of care, integrate the life goals of the patient in order to make sure that we can focus on the realization of that. And that's also why we have already made some conceptual work on how to link life goals with the daily practice of looking at episodes of care.
That's excellent. I have a question, but I hesitate to ask it because I don't know how long it would take to answer it. But I'm going to ask it anyway. That is that you've talked a lot about quality of life and what matters to the patient, and people do relate to that pretty well. Um, a bias of mine is that length of life is often as important or more important than quality of life, and that's not immediately apparent or on the minds of most patients. And yet, doctors are very concerned about trying to help people prevent uh, unnecessary death or premature death. Um, so, how does prevention fit into your concept of goal-oriented care?
I think that prevention is important, but it has always to live and to be fit in the life goals of the patient. And that's very important. Also, when, for instance, at a certain moment in time, you have a patient with multimorbidity, and then a new condition comes, can be a cancer or something like that. I think then we have to discuss with the patient how we are going to address that. And it can be that patient uh, focuses on quality of life and not on length of life. In Belgium, we are very open, and there is a lot of debate and open talk between doctors and patients on end of life. Nurses are involved, psychologists are involved. The topic of end of life, also because we have a legislation, therefore, specifically to make euthanasia possible in Belgium, and that is so. And family doctors play an important role in that. So early in life, we try already to discuss this issue with patients and then to see if in a multiple morbidity context new things arrive, how they perceive. And what we see is that it impacts heavily their life goals. And maybe sometimes then we have to be consequent and put the question forward, yeah, is a maximization of the regulation of the diabetes still needed when this patient is living with, for instance, a cancer condition and knows that the lifespan will be limited. And so together with the patient, then we can say, okay, for your diabetes, we take a kind of symptomatic option. So we are not going for the maximum optimal kind of regulation. We look how you can live without too much problems when it comes to your diabetes and address also the other needs that you have. And I think that this is the kind of talk that we need. That is, I think, important for the quality of life of the patient, but also it gives meaning to this period of life for them. And I think that is what our patients need so much. People have their physical needs, but they have also the sense of belonging. The importance of social cohesion in the society nowadays, and certainly in the political condition that we live in many countries, it is so important. People want to be part of a kind of social connectedness project. And we on the primary care, we can contribute to that by listening to the patients, by taking their life goals seriously, and by to modestly try to help them to make this life goals to be achieved in a feasible way that contributes to quality and that gives meaning to their life.
Thanks, Jan. I think we're going to have to end there, but I really appreciate you meeting with me today, and it's been great to see you again and to hear your thoughts about this. Thanks for all the work you're doing in Belgium. Hope to see you again soon.